Thank you all for coming today. This is a discussion of the proposed HCBS Access Rule, as it's been termed. On April the 27th of this year, the Centers for Medicare and Medicaid Services proposed some additions to federal regulations that implement Medicaid. The formal title for it is Medicaid and Children's Health Insurance Program Managed Care Access, Finance, and Quality. Actually, I may have put the wrong NOPRM up there because there's also a general uh, services access, finance, and quality notice of proposed rulemaking, which is actually CMS 2442-P. But this is intended to be a relatively impactful revision. For advocates, some of the proposals that they're talking about are revising the Medicaid Advisory Council, what is now known as the, I believe, Medicare Medical Advisory Council, MMAC in North Dakota parlance, to formally include more individuals with lived experience, that beneficiaries of Medicaid and or family members, 25% of those at a minimum. There's a plan or proposal to institute a grievance system for person-centered planning and service plans, which currently are not something that there is a hearing process to challenge. And there is a proposal for annual or biennial reporting on wait lists for 1915C waivers, wait times for the provision of services after someone is authorized to receive services, and utilized versus authorized hour ratio, as in if someone is authorized 200 hours per month, what on an annual basis at the department level is actually utilized of those authorizations, and what information does that give everyone about access to these services? Some things that are proposed changes of note for providers. One of the proposals is a provider rate advisory group that would, again, on a biennial basis, advise on changes to provider rates. There would be a requirement for 80% of the dollars that go for a service unit to go to direct care worker compensation for specific types of services, which would be homemaker, home health aid, and personal care services. Although that is actually one of the items that CMS has specifically requested additional comments on whether that should be expanded to more of the services that are offered under Medicaid, which might include in the DD division habilitation services. And there's also a proposal for a critical incident reporting system across the services provided by Medicaid, instead of, in our case, the critical incident reporting system that is, we have one for DD services, and what I understand, there is a there is another adjacent service within Therap that the QSPs use. This would be some sort of larger and more standard reporting. As I just went over, one of the changes of note for the HCBS direct care workforce is a requirement that 80% of the payment for personal care services by direct care workers has to go to the worker as compensation. Direct care workers is a little bit of a term here that's used differently than we immediately identify somebody as a QSP or a DSP. This definition is a little bit larger and includes some of the medical personnel like nurses, et cetera, that might be involved in formulating a plan or doing medication specific or medical license specific tasks for a person. There would be transparency on payment rates. There would be either annual or biennial, depending upon what in the proposal is adopted. Reporting on payment rates to direct care workers for all Medicaid fee-for-service payment rates. It would be publicly available through a published rate schedule available on a website put out by the state agency. Other changes that involve workforce are a regular review of payment rates every 2 years with an interested party advisory group that would specifically include beneficiaries of Medicaid. Also direct care workers and other interested parties impacted by the services. So every 2 years, there would be some sort of review and I presume comment or recommendation by people that are either providing the services or receiving the services. Now, they specifically asked for public comments on the proposed timeframe for the initial publication and biennial update requirements for the comparative payment rate analysis. That is a lot of words and small text. I apologize. What it means is they're asking for a time for people's input on the timeline for when would states be required to do the publication of the comparative rate analysis. They also wanted to know if there was any thought of an alternative, as in all the states reporting in the data on a comparative rate analysis and then CMS publishing themselves, and whether or not this should be a biennial or annual update. The categories of services subject to this rate payment analysis are supposed to be the most used services under Medicaid. That's why they've chosen this specific grouping. It's primary care services, OBGYN services, outpatient behavioral health, and personal care, home health aid, and homemaker services provided by individuals or agencies. There's also a specific request for comments on the feasibility and burden on the states to implement alternative ways to do a comparative rate analysis, either to Medicaid or other state Medicaid programs or Medicare or other state Medicaid programs or a national benchmark. So part of the access part of the title is a push for transparency in rates. How much is everyone paying state to state? And they're actively seeking alternative proposals for what they've come up with. If people think that a comparison to a different group of or a different service provision mechanism is more appropriate. There will be state reporting on what they term access to home and community-based services. That's a public report on 1950C HCBS waiver wait lists for states that have wait lists for their waiver programs, including the duration of that wait, and a report on wait time for approved services. There's also going to be a yearly report on the percentage of utilized authorized hours. That is something that reports out on, I assume, a per program basis, the percentage of hours that families are actually able to use from their authorized hours. Then there's another critical part of this in their minds is an incident reporting system with timeframes for investigation, resolution, and corrective actions related to critical incidents, trying for there to be a bit more customer service in this. Specifically, the request for reporting comments included, we also invite comments on whether there are other specific metrics related to the amount of time that it takes eligible individuals to begin receiving services, either in place of or in addition to the metric that they proposed. So if you have ideas or thoughts or can contribute lived experience on what might either have been a great experience in terms or something that unfortunately there was a delay. I think they'd like to hear about that. And specifically, how can they measure the timeliness of provision of services? And as I go through this, anyone feel free to raise your hands. I will try to respond to questions at a natural stopping point or in another 7 or 8 brief slides. There will have a formal stop for discussion after everyone has heard all of this. Now, the rate reporting is a piece of this just to report out who's paying how much for what. The current proposal is for for states to do a biennial rate, comparative rate analysis themselves. They're asking for comments on that in general. They're also asking for a comment if you have a strong feeling on an alternative proposal to have CMS instead of the states produce and publish the comparative payment rate analysis, which would, I presume, mean that the information is reported out in some fashion by the state to CMS, and then CMS does a nationwide comparative rate analysis. Some of the proposals are what I call feedback on services. That is, again, a grievance process for HCBS person-centered planning. Currently, because it is not a determination that gets some sort of fair hearing rights, there's no appeal, and the CMS proposal indicates that they would like to put one in place to ensure that there is a reassessment of the person-centered plan at least once a year, and the service plan is reviewed annually. And there would be, I believe, reporting out on how often the grievance process is utilized. And again, that may be something that you wish to comment on. One of the larger structural changes that is not related directly to state reporting is the Medical Advisory Committee. The proposal would add a dedicated beneficiary advisory group, or just going to call it the BAG, that includes current and or former beneficiaries and their family members to advise the agency on policy development. At least a quarter of the members of the Medicaid Advisory Committee must be from the BAG. One of the proposals that I've seen, or one of the responses to this proposed rule that I've seen, would be a suggestion that the rule is more explicit, that policy development means consultation with the advisory council members and BAG members prior to making major decisions. Currently, the Medicaid Medical Advisory Committee, as chartered, is authorized to review and respond to current Medicaid policy and or things that have been brought to the advisory council's attention. The discussion of this rule indicates that they wish the advisory council to have a more substantial role in policy development, which I think that we all agree that lived experience provides good context to rulemaking. And now, as I promised, I'm going to stop and let everybody that has been eating popcorn and watching me babble contribute to this. What do y'all think? You can either raise your hands and I can call on people, or just feel free to unmute and chime in.
This is Trina Dania. I got on about 4 minutes late. I just wanted to know if you were able to figure out that clarification question that I had posed it to you in an email. in regards to the 1915I? And you thought it did at one point that it would apply to the 1915I as well, is that correct?
The language of this rule, the application of it depends on how services are characterized. So if something is a type of service that they're proposing to be subject to that 80% rule, then all billings would have to be 80% compensation out to workers. However, they tried to narrow down the set of services that would be subject to that, so it's not always clear. I'd really have to parse the state 1959 application and see if they are personal services or homemaker or home health care. But they also wanted to know if they should expand that rate requirement past those particular services. And the rule is very clear that if that is a type of service that they are meaning to cover with that rate requirement, the 1959 would be included. But I believe the way the I is structured, that many of the services that are there don't necessarily fall into that category. And I think that my initial response to you was going to be, that's a good question and something that they should clarify, and I shouldn't be the one trying to explain what they're trying to do.
Sure. Okay, thank you.
And maybe that's a point of clarification. The m- m- Probably most of you understand this better than I do, but the set of services that they have under Medicaid I mean, there are different carve outs. Most of the DD habilitation services are not specifically covered by this proposal. However, they do specifically ask whether they should add those in. So, Pam? And Pam, if you're talking, you're muted.
I'm sorry, Dan, I'm having some computer problems.
Happens to the best of us.
So one of the things that I know we had kind of explored it, I've done a little bit of digging on, is that whole definition of personal care services. And I think that was when we first looked at this, one of the questions that we had. And from what we're finding at the federal level is that is a very, very broad categorical area of service, much more so than how we have defined it in North Dakota in some of our waivered services. And so I do think one area that folks may want to comment on is that the regulations be clarified to indicate what constitutes personal care services. Because I do think it's somewhat ambiguous right now based upon how they define it or how we define it within our state. And so I think, Trina, your question is really interesting and right along that line, because does that mean we get to decide as we define it, or are they intending to define it? Because then we have to look broader at it than what we perhaps would be if we were looking at what we call personal care services in our 1915C and 1915I services. So,
Thank you, Pam. Kayla, long time no see.
Yes, long time no see. I was just gonna say that I think that 80% is very hard to determine what they're looking for there, because there's obviously a lot of benefits that employees may receive that I would think would attribute to the 80% cost as well. That can't just all be administrative cost. Do you know what I mean? Such as fringe and workman's comp and all the other like all the variety of benefits, I guess, that are offered. So I think that's a clarifying question too, is like, well, would it be part of their 80% be part of their benefit package then? If you get what I'm saying there.
I know that there is some discussion, and they do link to a definition of compensation, which is the term that they're formally using, that would indicate that it covers a variety of fringe benefits. Whether it's everything, it remains to be seen probably in individual business by business situations. Jody.
Hello. So on these comments, is every agency going to send in their comments, or are we compiling them in one spot and sending them in from the state?
That is probably a question above my pay grade. My understanding is that P&A is going to submit comments on behalf of P&A. I assume that to the degree that it does impact the provision of services by HHS, either the department as a whole or some of the individual divisions will contribute comments where they feel necessary. But that's not a discussion that I can shed any light on.
One comment that I would offer is, I think in the past, when we've had situations of this nature, we have encouraged people to submit them individually, because if you've got 35 people that say the same thing, it carries much greater weight than if you have one comment and it's supposed to be a collective comment. It just doesn't have the same punch. So based upon our previous experiences with some of these types of things, I think if people have similar views, we should make sure that there's consistency in the message that's being sent, but they should be sent individually so that CMS really understands the magnitude of the comments and it just becomes a little bit more compelling.
Thank you.
So I guess I'd like to have some discussion from the members of the audience. Since P&A will be submitting comments, were there aspects of what I ran over that you particularly liked and think are particularly important? Or you specifically disliked? I should give both options. Brenda Schmid, that is.
Yes, this is Brenda. I specifically, I really liked, obviously looking at the authorized hours versus the utilized hours. I think that's significant. Just in representing and showing that yes, we are, someone is authorized and qualifies for these hours, but due to workforce shortage and other things, being able to utilize those hours isn't always possible.
And
I guess I have a couple of comments too. if you want them.
Yeah, go ahead, Sandy.
Yeah. Okay, so just a couple of things. With the 80% payment, we, there are some concerns on that, with cost to the agencies and how that's provided. That is that reasonable? Is that including the mileage that they have to pay their staff to get different places? I- really looking into and how is that going to be managed and reviewed? The timeliness of implementation. One of the concerns would be on the enrollee experience survey that to be annual. I know it says for managed care, but the 1915 C waivers or the I waivers, we have started working with and plan to continue working with NCIAD. But I do have a concern about that being annually and an oversampling of our population due to the sample size that we need to pull to survey those individuals. I'm concerned about asking that lengthy survey too many times, too frequently to the individuals, because it takes an entire year for that whole process to go through. And almost every single one of our recipients were pulled, and all of them were pulled under some of our funding sources to be surveyed because of the number you have to pull to get a representative sample. So it makes it a little bit concerning that we may be oversampling. We want the feedback, but I also don't know that it's realistic to ask our participants to complete an hour-long survey once a year when it may be almost all of them. So just kind of some concerns there.
I can see how that would possibly degrade the survey data if you have a certain amount of people that are getting frustrated and saying, nope.
Right. And then the other thought that I have is on the person-centered planning. With that, and it kind of goes against the how much is authorized compared to how much is utilized, because many times we will authorize the higher level, and then the individuals will choose to maybe have respite care, but some months they might not want as much respite care, or they it's really dependent on the needs and the individual changes to that person's care according to what they want. And sometimes we do authorize more services to ensure it's covered on months that they want that much services. So just a little bit of concern there on how person-centered are we getting if we're having some not allowed to authorize as much and some of those things. I'm just looking through the list. As far as reassessment and some of those grievance processes, critical incident reporting, under the HCBS waiver, we are doing a lot of those things already. So, and we do have those processes in place. So I don't believe what they're asking would be much of a change for our programming. But some of those other things like implementation of that survey may take longer for some states. And then it's because they haven't gone through the process, there's a shortage of vendors. It did take us 2 years to find a vendor to do that programming. So just some of those timeliness and rollout and weighing person-centered planning and what the individual wants and how they want to receive their care and the amount they need compared to saying, well, they're authorized and they didn't use that much every month. So now you're going to have to reduce services. Just wondering how that will impact people in our person-centered approach. So I guess those would be my thoughts.
Brenda, did you still have your hand raised, Brenda Schmidt, or?
Brenda Schmidt did not have her hand still raised, but I do have a comment though. So regarding back to the authorized and not utilized and the person-centered, I really appreciate what was said about that. With the person-centered care, obviously it's wonderful, but with that being said, having a daughter who requires one-on-one, again, with the workforce shortage and everything, it's very difficult for that person-centered plan to actually be carried out, just due to lack of staff available to help achieve that. So that was my comment. And my hand is down.
And this is Roxanne Romanic. I would just add to what Brenda said. I think somehow we're going to have to figure out how to collect some data on that. Because I think it's like subtle things like, oh, this person couldn't go today because there wasn't a male staff on, and there wasn't the ability to transfer this person. And then that never gets recorded, right? But I think the impact on individual programming because of the workforce shortage is way bigger than we're putting our finger on in regards to data.
And I'll go back to workforce shortage comments. Explicitly in the discussion that's in the notice of proposed rulemaking, the CMS is proposing that 80% minimum rate requirement, 80% of the rate for a given personal care service or home health care service goes to the direct care worker, explicitly as a workforce retention device. If there are alternatives that one can suggest, or different ways to address that problem, I think that might be something that would be a fruitful comment for them for CMS to see.
Dan, I can't hear you. I don't know if you're talking to the whole group, but.
Or I could take my mute off. There is a comment in the chat that there needs to be a listing of persons that are not able to utilize or fully utilize an authorized service. I think that dovetails back with what Roxanne said about more subtle data collection, asking the next question of why someone is not fully utilizing an authorized service. Is that, as Sandy said, a choice for a given month, shifting hours from one point in life to another? Or is that something to do with workforce shortage? That reporting would be useful to address the point that they want to do that with. We have another question in the chat as to the proposed revisions of the Medical Advisory Committee and that beneficiary advisory group. Do people like that? Is that something that you can see yourself putting organizational time and effort towards to contribute to? Do you think that will have a a use in expanding access to services? Anyone?
Dan, I commented in the chat. I would really like to see somehow these committees combined, because I think all of the necessary people from the professional side of things needs to hear input from people that are utilizing the service. And by having a separate group that is just, beneficiaries, just really seems segregated to me. So I'd like to see them combined, but that's just my personal opinion.
Well, they are very specific that 25% of the members of the MAC should be from the beneficiary advisory group, and they did express some concerns that the work that would be expected if the MAC is doing substantive input on policy development would be significant and dissuade people from entering it. But I also hear what you're saying, that part of the point of persons with lived experience is to provide context and feedback. And if that's not being heard by, if those voices aren't being heard, or if they're being heard second hand, that isn't quite as effective. Anyone else have thoughts on the role of the beneficiary advisory group? They did question whether or not that should be a higher percentage, or if it should be a somewhat different percentage of the MAC. The MAC is supposed to involve provider groups as well as the state level agencies and advocacy groups. But since it is supposed to be some inclusion of lived experience, should it be something like the DD Council where it's 50% or more?
This is Brittany. I think that any committee, council, or whichever that is advising on or commenting on any services should be at least 50% majority, or 50% or a majority of those who are receiving, or a family member representing somebody who's receiving services.
And keep in mind that the titling of this is a pointer in a given direction. This is supposed to be about HCBS access, how to better get people in touch with services and ensure that that service provision mechanisms are being effective. So if there are pieces of this that you like or don't like, they are openly suggesting that you suggest alternatives. I think that we all understand that this is a big, complicated area of services, and no one person or one agency is going to have the magic bullet. I'm hoping that they will take the comments that they're being given, because there are a lot of people at this particular table, all of whom have a valid insight on details of this that need to be managed.
Dan, did you look into anything more with the streamlining as far as access?
I'm not entirely sure what you're referring to there.
When it was talking about access, it was referring to streamlining of, I'm assuming, eligibility as well as probably redeterminations and whatnot. And I know there's been a lot of that talk over many years in North Dakota, but the annual recertifications or the multi-agency that are involved in eligibility and recertifications, there's streamlining of the access, the simplicity piece, so that people can get information as well as become eligible and then access the services that they're authorized pretty quickly. It was all kind of wrapped in. I just didn't know if there was any other information there.
I think that that's because I haven't been through the eligibility process, not something that I have the first, it's not foremost on my radar, and it's definitely something that I don't have lived experience commenting on. But yes, they are asking about, they say in this, the first dimension of access focuses on ensuring that eligible people are able to enroll in the program. So if there was a previous streamlining eligibility proposed rule in September of last year, this is more access to services, but I think the focus has been on actually getting services to people. If there's something about the eligibility process that inhibits access, that may be a fair game for commentary. But Brenda Schmid?
Yes, so I didn't see anything in there, specifically, and we did talk about, the regulations being clarified, about personal care services and more clarification there. But just from lived experience, we do self-directed for our daughter. And just again, with the workforce shortage that it is, and providers struggling, we've chosen to do the self-directed. I think there maybe will be more and more families deciding to go self-directed, but I found that whole process super clumsy and clunky and difficult to actually get to a point where I'm now successful at it. So I was just wondering if anywhere in there self-directed is in the mix of all this. And I don't know how to put my hand down, so you can put my hand down for me, please.
Will do. I don't directly know how to respond to that, Brenda. There is a lot of pieces here, and are you indicating that, as Roxanne was talking about subtle data collection, that actually the self-directed services pool within North Dakota should be a part of any feedback on services to ask, let's say, a gateway question as to why are you choosing self-directed services instead of going through an agency or provider?
You want me to answer that?
No, I'm just, well, maybe that's a comment to say that it should be part of the data collection, that actually, if there's been a self-selection process for people that are doing self-directed services because of larger frustrations with complications on getting services, that should be a part of the access to HCBS information that they are collecting.
I think that would be a really great question. Yes.
And later on, I will show you how you can make that comment to the federal government yourself.
Thank you.
Brittany.
I was just going to clarify that with Brenda's comment that self-directed is not the service option, but it's the mechanism of using that service option, because there's equipment, supplies, respite, in-home supports. But that in-home supports is a personal care plus supervision service from the way that I understand it. So it would be subject to the 80%. And then there are a number of states that offer far more services in a self-directed model, and that kind of goes back to the person-centered planning. If there are supports or capacity to be able to self-direct, it is self-determination and everything else that we're supposed to be supporting, that services can and should be able to be directed by the individual or their caretaker and support team. But all of that kind of wrapped in.
Okay. Is there anyone else that wants to contribute to this discussion, or should we move on to a discussion of the commentary mechanism?
sorry, I had one other question. I had to tune out for a few minutes. Did you guys cover the wait times?
I did mention that it
Part
was
of it?
one of the topics that they had proposed doing reporting on. I don't know that anybody has specifically discussed reporting on that. Did you have a specific comment?
I just hadn't looked into it that far to know if it was reporting on the wait times to access or utilize those services, or if there was some sort of cap on the wait times that CMS was proposing.
It's a proposal that there be reporting on what the time differential is between authorization, determination of eligibility for services and actually being able to utilize those services. All right, throwing that out for the good of the order and seeing no hands raised or shouts of stop, I will share my screen again. Comments on this are due on July the 3rd. That's roughly 2 weeks away. I wanted to have this discussion so that people can go off and have any sort of thoughts that they're going to have and then submit them and still have the better part of a week to do it before we all leave town and leave our worries behind and go off on the 4th of July holiday.
And Dan, if I read it correctly, and so I'd be curious if folks understand this to be the same, that they have to be received by that date. So if you snail mail them, make sure that you're allowing adequate time. If you submit them electronically, then of course, it's easier to meet that deadline. But the statement was comments are due and must be received by. So if I read that correctly, if you mail them, just allow adequate time.
If you think of the must submit date as June the 30th, you won't be doing yourself any disservice. There is an electronic portal, regulations.gov gives you the ability to submit an electronic comment. And there are also advocacy groups that have portals for comments. One that I found was for the Autism Society. They are running a portal that will allow you to enter in your information and enter in your response to that. Not that we are formally endorsing the Autism Society's platform on this, just that they are an example of things that you can find out there with a little bit of looking to lend your voice to a particular set of concerns as a group. The advice that they will give you on the federal regulations site is specifically that if you have lived experience, please provide that. Comments are most effective when they provide information directly relevant to analyze the rules and its effects. Tell your story. Tell the people that are looking at these comments what you believe that change will mean to you, or how their change could be slightly different and be better for your situation. After comments, this goes into what's termed the final rule stage. The comment period closes. The agency reviews the comments received, does an analysis, and then they decide whether to proceed with this rule, issue a new or modified proposal, or withdraw the proposal. So your comments can have a significant impact on this going forward. And we encourage you to use your voice for advocacy, because you're all here for a reason. This is all important to your life. Again, www.regulations.gov, and anybody that is here, please email me for any information that you've seen on here. I can email you a copy of all the slides. And there's also the CMS article fact sheet on this done by, I believe it's Allison Barkoff, who's last with the Bazelon Center for Mental Health, but a long time advocate in this area, explaining why this set of rulemaking has been done and giving a brief synopsis of this. So that's available at cms.gov. And again, anybody that wants these slides or the links that I mentioned, just please email me and I will gladly send those out. So it's 9 minutes to the end of the hour. I can give everybody 9 minutes of their life back. Are there any further comments? If not,
This is, oh,
Jess?
sorry. Out of curiosity from the bullet points earlier, and I joined late, did we cover like create a new payment transparency requirements for states by requiring disclosure of provider payment rates, both fee for service and managed care, with the goal of greater insight into how Medicaid payment levels affect access to care? Did we talk about that?
I glossed over that. You have just explained it in a far different level of detail than I did. What from the person that does the books at Enable's perspective, what concerns might you have with that? Or do you think that that is a great way to go about this?
Well, my question would be is that every state kind of has their own payment system. So I don't know how creating a new payment transparency requirements for states, how that would actually flow to every state, because every state has their own way of calculating what the reimbursement rate is for an individual. So unless they would make every state convert to the same way, which as some of us like part of the legislative process, as we all know, like even trying to get parents paid as the Paid Family Caregiver Act was put out there, they stated that it would take multiple years to kind of get that up and running kind of thing and get a whole new payment system just for North Dakota. And we couldn't really piggyback off how Montana did it or South Dakota. Like every state comes up with their own. I just don't understand how they would do that, create a new payment transparency of requirements, like, because every system is a little bit different. We also state, as being a financial person, even the state right now is struggling with the payment system because they actually, with what they're providing providers now, because the legislator said that everybody had to get, anybody that was a direct care worker was supposed to get $1 raise. When the state tried to put that into the recalculation of what they pay providers, they actually ended up changing the payment system from what it used to be. They literally changed the payment system that we've been following for 5+ years because of how they put the dollar into effect. And when it brought up to them, they didn't realize that they changed the formula forever. Basically, there's no way to ever go back with how they added that dollar in. So I just be curious how they think that they would do that for all states, just have one blanket statement.
Well, maybe that's a good comment to submit. They did ask for alternative proposals in that area, as in, should there be how should we make these comparisons? Should we be comparing this to Medicare rates? Should we compare state to state? Should it be CMS that actually receives the data and compares rates between, between different services and between states? And if
Yes, this
any
is
of,
Brittany. Oop,
go ahead.
sorry. No, I was going to say to her comment, I thought you guys commented as well as what I understood is that much like many of these proposals within the proposal is that the requirement be that the state develop, the requirement is to be transparent so that the state develop payment system transparency and reporting, and that it could be individualized, or the whole submitting it to CMS and then they try and do it, which I agree, don't think would be a good option because of the variability between each state, and just that seems like it would be a mess. But that I feel like it did have that individual states required, and so then it wouldn't be